Well, hello, everyone, and welcome to our April CMF Podcast. I'm Professor Meg Jardine, Director of the NHMRC Clinical Trials Centre at the University of Sydney and Director of the CTC's Kidney Health Research Program. The CMF is a free educational resource for clinicians, and this podcast aims to update you on some of the latest publications in the field of cardiometabolic diseases. So today I'm really pleased to be joined by Professor Hiddo Heerspink.
Hello, I'm Hiddo Heerspink, Professor of Clinical Trials and Personalised Medicine at the Department of Clinical Pharmacy and Pharmacology at the University Medical Center in Groningen, the Netherlands. We will be discussing the main findings of 3 publications from the monthly literature searches in March and April and what they mean for clinical practice.
Well, let's turn to our first study, and this is one you're very closely aligned with, Hiddo. I think, in fact, you're the first author, aren't you? And we're going to talk about a paper you recently published on the effect of semaglutide on albuminuria and kidney function in people who are overweight or have obesity with or without type 2 diabetes. And this is an exploratory analysis from the step 1, 2, and 3 trials. You were the main author. What do you think are the main outcomes from this study, and what should we know for clinical practice?
Yes, thank you, Meg. We published this paper last month. And before talking about the clinical implications, I will give you a short summary. So in these STEP trials, semaglutide markedly reduced body weight and improved glycemic controls in adults with overweight or obesity. Semaglutide, developed initially for type 2 diabetes and then for overweight, was tested in these trials at a dose of 2.4 milligram per week, whereas the dose for diabetes is 1.0 milligram every week. The effects on albuminuria and eGFR decline in these patients or people with overweight or obesity were unknown. So we assessed in a post-hoc analysis the effects of semaglutide on albuminuria and GFR decline. So the trial enrolled patients with overweight or obesity and assessed the effects of semaglutide on albuminuria during 68 weeks of follow-up. We also explored the effects of GFR decline in all the trials, step 1, 2, and 3. The main analysis was done in patients participating in the step 2 trial, which included patients with type 2 diabetes, and in this trial, albuminuria was assessed. The trial randomly assigned patients to semaglutide 1.0 or 2.4 milligram subcutaneously administered every week or placebo. And during follow-up, it was clear that semaglutide at doses of 1 or 2.4 milligram reduced albuminuria by about 30% after 68 weeks of treatment. These effects were consistent in patients using or not using ACE inhibitors or angiotensin receptor blockers, and importantly, effects were also consistent in patients already using an SGLT2 inhibitor or not using an SGLT2 inhibitor. When looking in the combined pooled analysis of the step 1, 2, and 3 trial involving about 4,000 patients, there was no effect of semaglutide on the rate of kidney function decline. However, I should mention that the majority of these patients had a normal kidney function to start with, and the rate of decline in these patients in the placebo group was small. So in hindsight, I don't think we could have expected an effect on the rate of kidney function decline in these patients. So Meg, these are the main findings of the publication.
Right. Well, yeah, thanks for outlining that. So I think it's important to understand that these were not people who were progressing in terms of loss of kidney function. But can I go back to the reduction on albuminuria? As we know, albuminuria is a really important marker of kidney and of cardiac risk. That drop of 30%, how do you think that, how clinically significant would you say that is?
Yeah, I think this is a really important question because we have to understand what a drop of 30% means for clinical practice. From a meta-analysis published a few years ago, we know that a drop of 30% in albuminuria during follow-up with a drug is associated with a very high likelihood that the drug will also protect against clinical kidney outcomes, such as end-stage kidney disease or doubling of serum creatinine. And we know that ACE inhibitors, angiotensin receptor blockers, as well as SGLT2 inhibitors reduce albuminuria by about 30%, and these drugs have been proven to be kidney protective. So I expect that semaglutide will also protect the kidney, but we don't know because there are no dedicated outcome trials, kidney outcome trials completed as of today.
But what do you think is coming down the track?
Yeah, of course. The FLOW trial is currently ongoing, which is a dedicated kidney outcome trial in more than 3,500 patients with type 2 diabetes and chronic kidney disease. The baseline characteristics of the population and the study design was published in January this year. And it is expected that the trial will complete by the end of this year or early 2024. Well, based on the findings from this trial and this publication published this month and previous analyses from the semaglutide program, I would expect that semaglutide would protect the kidney even on top of a current standard of care. But of course, we need the proof, and we are eagerly awaiting the results of the FLOW trial.
Yes, and another exciting day to come, I hope. But that point you made about some patients in this trial already being on an SGLT2 inhibitor and on RAS blockade. So that's really important to know, isn't it? That there's expected effects would be on top of, as you say, best current care.
Yes, that's very interesting because it would suggest that even in patients in whom albuminuria cannot be optimally controlled and who are still at high risk of progression, we probably have a new agent that can confer additional kidney protection. It also speaks to the mechanism of action because it's likely that GLP-1 receptor agonists protect the kidney through different pathways than ACE inhibitors, ARBs, or SGLT2 inhibitors. And from that perspective, a dedicated mechanistic study, ReModel, in diabetes and SMART in non-diabetes are ongoing to further explore the underlying mechanisms of GLP-1 receptor antagonists.
Good. And any safety signals that came up in these trials while we're waiting for the big results of FLOW?
No new safety signals as compared to what we already know. Gastrointestinal side effects were more common in the semaglutide compared to placebo group. Meg, shall we continue with our second paper, which is about finerenone in participants with stage 4 chronic kidney disease and type 2 diabetes. Meg, you have reviewed the paper, and can you tell us a little bit about the content and the potential clinical implications?
Yes, happy to, Hiddo. So another exciting development of the MRAs. In this particular study, this was a sub-study of the Fidelity data set. And in this one, patients with stage 4 CKD and type 2 diabetes were analysed. You know, as we know, these patients have limited treatment options to reduce their ongoing cardiovascular risk and kidney risk. We know from the Fidelity program, which included Figaro and Fidelio, that finerenone had overall benefits, cardiovascular and kidney benefits in patients with type 2 diabetes and chronic kidney disease. But in this paper, we're going to look particularly at that subgroup that had stage 4. That's people with an eGFR at baseline of 15 to 30 mils a minute. So in this group, the average eGFR was around 27 mils per minute. And they had relatively high albuminuria with a urine albumin creatinine of 720. So overall, they were able to include 980 people in this analysis, which is a reasonable size for this population. And what they found was that there was a higher proportion of cardiovascular events occurring in the patients with stage 4 CKD versus patients with earlier CKD stage. That's not so surprising. We know there's patients at higher risk. Overall, the benefits of finerenone on the cardiovascular composite were not different according to the different stages of CKD severity. So consistent effects, relative effects, which is reassuring. In people with stage 4 CKD, the risk differences over time suggested a reduction in the risk of kidney outcomes. And in this study, that was a sustained 57% eGFR decline or doubling of serum creatinine in the old terms, or kidney death. And that was over the first 2 years. But the effects weren't so consistent after the 2-year endpoint. And the other important finding from this study was that the safety profile was the same for these patients with stage 4 CKD compared with the overall population. So overall, yeah, look, I think the important things to emphasise here is that we've got a greater depth of data for these patients who are at very high risk of both cardiovascular and kidney events.
Yeah, and when reading the publication, of course, for me, a main and difficult to interpret finding is that difference in effect of finerenone during the first 2 years and the subsequent years of follow-up. Because during the overall follow-up, in particular long-term follow-up, there appeared to be no benefit of finerenone, whereas this benefit was particularly observed during the first 2 years. What is your interpretation of this finding?
Look, it is interesting. We have to be a little cautious because it is a subgroup analysis. But what we also know about patients with low eGFR is there can be quite a mixture of patterns of progression. Some people are clearly heading and moving quickly towards dialysis. There are some people, though, with low eGFRs who are very steady, and we've seen that in some other trials. So I wonder if part of the effect here was that those people who are at risk were very close to the threshold, and so they got there in the first 2 years if they were progressors, and if they weren't progressors. So I think that's most likely the outcome. Obviously you can't have an effect once your at-risk population are already on dialysis.
So in your clinical practice, suppose you have a patient with a GFR of 19 or 20, CKD stage 4, would you treat that patient with finerenone, understanding that in the trials conducted so far, the lower GFR threshold is 25, but there's also a consistency effect across CKD stages.
Yeah. Look, at the moment, I think my main concern would be about cardiovascular risk or not. I mean, the strong benefits here for these drugs are for cardiovascular protection, and we know people at stage 4 are at really high risk. For the kidney protection for these agents at stage 4 at the moment, I think I would be a bit cautious about the patient with an eGFR of 19 or 20. If for no other reason than that they're numerically they're close to threshold and people can overreact to any changes. So if I had a patient with a very high cardiovascular risk, I think that would what be driving my decision making. The other aspect, of course, is potassium. Now, we know these agents don't have the same impact on hyperkalemia as agents like spironolactone, and that's reassuring. But there still is a slight excess of hyperkalemic events. And so, again, I'd be looking at the individual patient and assessing their risk. It may be, of course, that cardiovascular benefit is really strong. There are ongoing trials, as you know, of spironolactone in the dialysis population. And if they show benefit, I think it'd be it's very plausible that finerenone may also have benefit, but that information is yet to come. And I think the potassium outcomes will be something that we all look at closely.
Yeah. And then finally, the Fidelity program enrolled patients with type 2 diabetes. But what about patients without type 2 diabetes? Are you considering finerenone for that population?
Oh, look, I think that's a really good question. There has been such a focus on people with diabetes and chronic kidney disease. We're now looking at the rest of the population. I think it's a really good question, as is the question of whether combinations of these agents with other proven protective agents like the SGLT2 inhibitors. And fortunately, as you know, there's a trial ongoing that looks at those combinations. So I think that will be really interesting, potentially to a good strategy for mitigating the hyperkalemic risk.
Yeah. All right, so more to come also for patients without diabetes with respect to finerenone.
Yes, look, it's worth thinking about some of the other agents that are available. For this population, it's the cardiovascular risk that often drives outcomes, and there are more and more agents coming through. There has been a recent review paper. Should we take a moment to talk about that?
Yeah, sure.
So this one, I found a very useful summary. I'm a nephrologist, as you know, Hiddo. I'm not a cardiologist, but I found this paper a good summary of the recent evidence in the area. And if you're time poor, that's what you want, isn't it?
Yeah, exactly. It's a very nice review about new treatment options for patients with heart failure and reduced ejection fraction. But I find it very interesting that many of the drugs discussed in this review have also kidney protective effects. The paper reviewed, for example, SGLT2 inhibitors. They reduce the risk of heart failure, but equally reduce the risk of kidney failure. The paper discussed the role of sacubitril valsartan, neprilysin inhibitors for prevention of heart failure. But from the trials conducted so far, we know that this drug also reduced the risk of kidney failure in these patients with heart failure. The review talked about MRAs. Well, we just talked about the role of MRAs in kidney failure. So it closely illustrates, or nicely illustrates, the close connection between kidney failure and heart failure. They often go hand in hand. And the drugs that are used for heart failure can also be used to slow the progression of kidney function decline.
Yeah, I mean, that is such an astute observation. But we used to really separate people into different disease areas. But what's become really clear in these big trials is that the people at risk of kidney disease are often the people at risk of cardiovascular events, and particularly heart failure. I think that makes it really exciting because it's, in a way, it's making it easier to conduct trials. You don't have to search for obscure, popular or rare populations. It's the people who are at risk for multiple morbidities, also the ones who stand to benefit from agents that are successful. So I did find that really interesting. I also found some of the newer agents interesting to read about, the guanosine monophosphate pathway inhibitors. I thought that was an interesting area of development. I don't know if you had thoughts about those agents, Hiddo?
Yeah, I know this is a very interesting class of drugs. They target the nitric oxide pathway, and of course we know that nitric oxide and endothelial dysfunction is common in chronic kidney disease as well. And I know that there are a couple of phase 2b trials ongoing with this class of agents, and the results are expected to be released in the near future. So an interesting area of research. What I also found interesting was the final paragraphs of the review talking about inflammation and the role of inflammation in the pathophysiology of heart failure. Similarly, we know that inflammation is involved in diabetic kidney disease. The therapies tested so far, at least in heart failure, but again, equally in chronic kidney disease, have failed to demonstrate a clear benefit. So although inflammation is involved in the pathophysiology, we haven't been able to demonstrate the value of anti-inflammatory drugs with respect to the treatment of heart failure and also kidney failure, which I found was also interesting.
That is so true. It's been a target for a while, but we haven't managed to land a successful intervention. So it does make you wonder, are we looking at a true underlying cause, a causal point on the pathway, or are we looking at a surrogate, or are we just intervening too late?
Yeah. Well, we'll see more results of new anti-inflammatory drugs also this year, early next year, for example, IL-33 inhibition. So let's see what the future holds with respect to anti-inflammatory drugs. So, Meg, I think we have reviewed 3 excellent papers, and I hope that you have enjoyed the discussion in this podcast and find it useful to inform your clinical practice. For slide summaries on further publications, I'll guide you to the CMF cardiometabolicforum.com. And if you want to stay up to date, join our mailing list and follow us on social media to find out when more slides or literature highlights and podcasts go live. I thank you for listening to us.
Bye, everyone.
Bye-bye.